What if we could actually, train our bodies, prepare them to withstand extreme stress, maybe gear up for major medical challenges even before they happen?
Hmm.
Think about facing down something like a really complex surgery or maybe an intense, potentially hostile environment, not just reacting in the moment, but having already built up some kind of internal uh, biological resilience.
That's a pretty profound shift in thinking, isn't it? It really moves us from purely reactive medicine or, emergency response into this realm of proactive biological conditioning. We're
Huh.
essentially enabling the body's own protective mechanisms ahead of a predictable insult.
Absolutely. And that fascinating concept, that's exactly what we're embarking on a deep dive into today. We're exploring the world of oxygen pretreatment and preconditioning this idea that strategically timed exposure to oxygen, whether it's at normal atmospheric pressure or significantly higher pressures, can actually induce protective changes within our physiology.
Yeah, and our guide for this specific exploration is a deep analysis of Chapter 19 from a key text in the field. It's a chapter titled Oxygen Pretreatment and Preconditioning, authored by Enrico M. Camporese, Matteo Paganini, and Gerardo Bosco.
Right.
And this chapter really pulls together insights from quite diverse areas where this principle is being investigated and, well, applied.
So our mission in this deep dive then is to take this chapter and really thoroughly unpack it. We want to extract every important nugget of knowledge, understand the fundamental definitions and the mechanisms at play. We'll look at the established applications, particularly where this has a long history, like in
Oh.
diving medicine,
Mm-hmm.
and then really explore the intriguing emerging uses in hyperbaric medicine for those critical clinical scenarios.
Right.
We're talking major interventions like cardiac surgery, procedures involving the central nervous system, and, complex major abdominal surgery.
And we'll also take a peek into the exciting perspectives for future research that the authors hint at, trying to understand where the unanswered questions lie and, well, where this field is heading. We're going to parse through the source material, aiming to uncover every detail that holds clinical relevance for you, our specialist clinician listener.
Okay, so consider this our roadmap. We'll start with those fundamental definitions, the core rationale behind preconditioning. Then we'll journey into its vital, established role in diving. After that, we'll move into the frontiers of its clinical application, and we'll finish by examining the paths future research is likely to take. It's kind of a journey from preventing bubble trouble beneath the waves to potentially mitigating the significant risks tied to major surgeries.
Sounds good. Let's begin by laying that essential foundation then, defining exactly what we mean by pretreatment and preconditioning in this specific context.
All right, let's establish the groundwork. The authors, building on work that dates back at least to Murray in 1986, they provide some pretty clear definitions. They define pretreatment as the act of exposing a patient or, more broadly, a subject to a controlled stimulus before a crucial and similar event is expected to affect that subject. It's a deliberate action taken in anticipation of a known challenge.
That controlled stimulus part is really key, isn't it? It's not just some random exposure, it's a planned intervention.
Mm.
And the expected event, it should be in some way similar to the stimulus, or at least the stimulus is chosen because it's believed it will prepare the body for that specific type of event.
Precisely. And the intended outcome, the desired result of that pretreatment, that's called preconditioning. Now, this is defined as the induction of physiological and, well, pathophysiological protective changes within the body.
Oh.
The source describes these changes as potentially involving genetic or enzymatic modifications. So we're not just talking about some temporary chemical buffer here. The idea is that this pretreatment triggers the body to actually alter its internal machinery, its genes or the enzymes they produce, become more resilient.
And these induced changes, the state of preconditioning, it's designed to protect against very specific types of damage. The chapter specifies damage that is predictable, extreme, environment-induced, or disease-related. That's a pretty broad scope, actually, which hints at the potential applicability we'll be discussing later, everything from planned surgeries to environmental extremes like deep diving.
And in the context of this chapter, the specific stimulus we're really zeroing in on is oxygen. So oxygen preconditioning, therefore, occurs after exposing the subject to oxygen breathing. This could be either at normobaric pressure, which is just standard atmospheric pressure at sea level, or at hyperbaric pressure.
Right, and hyperbaric oxygen, just to clarify, is delivered at pressures greater than 1 atmosphere absolute, usually inside a hyperbaric chamber. This allows for much higher partial pressures of oxygen to be delivered right down to the tissues.
Yeah, exactly. And the authors emphasize a really critical point here. The duration and the modality, meaning is it normobaric or hyperbaric oxygen of the pretreatment, are absolutely critical. They state that these factors actually influence the preconditioning modality itself.
Okay, so what does that mean exactly?
Well, it means that different oxygen protocols, varying in pressure and how long you breathe the oxygen, they lead to different patterns of gene and enzyme expression down at the biomolecular level.
Mm.
And importantly, these different biomolecular responses ultimately result in different macroscopic or, observable outcomes at the level of the whole organism or organ.
So it underscores that the specific details of the oxygen exposure protocol, they matter immensely. It's not just give oxygen.
Exactly. The dose and how it's delivered aren't just minor details. They really dictate the nature of the protective response you get. So let's look at some practical forms of oxygen pretreatment that are mentioned. One of the most straightforward and historically used applications is short-term normobaric oxygen exposure, often at 100% inhaled for just a brief period. The primary immediate goal here is simply to increase the body's oxygen reserves, essentially topping up the oxygen stores in the lungs and blood.
And a ubiquitous example, something you see in everyday clinical practice, is pre-oxygenation right before the induction of general anesthesia. This is a standard safety maneuver done pretty much universally.
Why do we do it?
Well, it's to prevent dangerous tissue deoxygenation that can occur during that period of apnea, the cessation of breathing, that happens after you give the anesthetic agents, but before you get effective ventilation or intubation established. This is particularly crucial in patients where you might anticipate a difficult airway or where there's a risk of prolonged laryngoscopy time.
And the source gives specific patient examples where these risks are higher, and pre-oxygenation is especially vital. Pregnant women, small children, and the obese population.
Right. These groups often have a lower functional residual capacity, basically smaller oxygen reserves in their lungs, and they can deoxygenate much, much faster than healthy adults. So pre-oxygenation effectively buys you precious minutes of safety time during that critical phase of airway management.
Beyond the operating room, this short oxygen pretreatment has also been historically used in extreme environments, like by breath hold divers. By breathing oxygen before a dive, they increase their oxygen stores, which helps to prolong their useful apnea time, basically, how long they can stay underwater before the rising carbon dioxide drives that urge to breathe, or before their oxygen levels get critically low.
Okay, so that's the short-term boost. But the chapter then delves into something perhaps more nuanced, the peculiar physiological and pathophysiological responses that are observed during and significantly after extended oxygen exposure.
Yeah, they give a specific example. Prolonged inhalation of oxygen, say, for 1 hour, while at rest at sea level, so under normobaric conditions. What happens? Well, there's a significant decrease in both heart rate and cardiac output. The heart actually slows down and pumps less volume per minute.
Interesting. And in parallel with that reduction in cardiac workload, there's an observed increase in peripheral vascular resistance. So the blood vessels out in the periphery constrict, which tends to increase the pressure needed to perfuse tissues, even though the overall flow, the cardiac output, is actually reduced.
And the probable mechanism suggested by the authors for these cardiovascular and hemodynamic changes, it seems to be the effect exerted by hyperoxia, that state of having higher than normal oxygen levels on the autonomic nervous system. Specifically, this prolonged oxygen exposure seems to cause a reduction of sympathetic tone, the fight or flight system, and a concurrent increase of parasympathetic tone, the rest and digest system. The balance shifts, favoring parasympathetic dominance, and that leads to the observed bradycardia, the slowed heart rate, and reduced cardiac output.
And what's particularly noteworthy about this effect is how long it lasts. The source states that this autonomic shift and its associated hemodynamic changes can persist for more than 1 hour, even after the subject has gone back to breathing normal environmental air.
Right. That lingering effect is a key feature, suggesting a sustained influence on physiological regulation.
So what's the potential clinical utility of these specific prolonged oxygen-induced effects?
Well, the authors propose that these changes, the slowed heart rate, reduced cardiac output, increased peripheral resistance, and that underlying shift in autonomic tone could potentially be helpful. They might counterbalance dangerous, non-physiological responses to certain environmental or clinical situations. You could imagine a scenario where you anticipate a big surge in sympathetic activity, Maybe preconditioning with oxygen could blunt that response.
Okay, that makes sense. And the scope of the discussion in this chapter, as the authors clarify, really focuses on the effects of protracted normobaric oxygen exposure and prolonged hyperbaric oxygen pretreatment.
Yeah, they specifically differentiate this from the prolonged and maybe repetitive use of oxygen you see in, say, high-altitude mountaineering, aviation medicine, or space medicine. The pressures and contexts there are significantly different, often involving adapting to chronic hypoxia or weird atmospheric compositions rather than preconditioning for an acute insult. It's a different ballgame.
Right. So we're really focused here on these deliberate, often quite significant oxygen exposures designed specifically to elicit a protective state. The goal, as stated, is to show the known biomolecular and macroscopical changes that result from this type of oxygen pretreatment, both in the well-established area of diving medicine and then in selected, perhaps more experimental, clinical situations.
Okay, perfect. So just to quickly consolidate what we've covered in this foundational section, we've defined pre-treatment as that deliberate stimulus before a challenge, and preconditioning as the resulting protective biological changes, which might even involve genetic or enzymatic modifications.
Right. Oxygen is our specific stimulus, and its duration and pressure, normobaric versus hyperbaric, are absolutely critical determinants of the resulting preconditioning.
And we saw that short-term normobaric oxygen is a clinical staple, mainly for boosting oxygen reserves, especially before anesthesia. But prolonged normobaric oxygen that elicits these fascinating physiological responses like decreased heart rate and cardiac output, likely due to shifts in autonomic tone, and these effects can last for over an hour.
This really lays the groundwork for exploring how these principles are applied to prevent harm in specific situations.
Excellent. With that understanding of the basic concepts and those initial physiological responses, let's shift our focus now to a domain where oxygen pretreatment has a really tangible and established role: diving medicine.
Okay, Section 2. Diving medicine applications preventing the bubble trouble, as you called it earlier. Oxygen pretreatment isn't just some experimental concept here. It's actually successfully utilized across various diving disciplines: recreational, technical, commercial, even military diving.
And the primary purpose, as that subtitle suggests, is explicitly to prevent potential complications connected with underwater activities. The big one, of course, being decompression sickness, or DCS.
And it's really vital to distinguish this preventative use of oxygen pretreatment from the treatment of decompression sickness itself. If a diver actually experiences DCS symptoms, immediate normobaric oxygen administration is fundamental first-line therapy.
Absolutely.
As discussed in Chapter 8 of the larger text this chapter comes from, that immediate oxygen treatment is often life-saving. It helps reduce bubble size and facilitates inert gas washout during transport to a hyperbaric chamber for definitive recompression treatment. What we're focusing on today is using oxygen before the dive to try and reduce the risk of DCS happening in the first place.
It's the difference between building a stronger wall and fighting the fire after it's already started, right?
Exactly. Now, the development of decompression sickness is driven by two main features associated with coming up from depth. First, there's that rapid decrease in hydrostatic pressure as the diver ascends. Second, this pressure drop causes inert gas, primarily nitrogen that was absorbed under pressure, to come out of solution.
And these gases can then expand pre-existing gas micronuclei into clinically significant bubbles, forming within tissues and the bloodstream.
Which brings us neatly to the micronuclei hypothesis and the whole process of denitrogenation. Early concepts, which have been supported by later research, suggested that these tiny gas micronuclei, made up mainly of inert nitrogen, actually exist within living tissue even under normal conditions.
Like tiny stable pockets of gas?
Precisely. Microscopic stable pockets of gas that act as seeds or nucleation sites for bubbles to form upon decompression. And recent research cited in the chapter has provided confirmation that pre-treatment with either normobaric oxygen or hyperbaric oxygen can significantly impact this whole process. It can significantly remove nitrogen from tissues, reduce the population of these micronuclei, and thereby prevent or significantly reduce bubble formation after a subsequent decompression.
Okay, let's try and visualize the mechanism proposed for how oxygen actually tackles these micronuclei. So imagine you have this tiny nitrogen micronucleus sitting in the tissue.
Right.
When you breathe a high concentration of oxygen, those oxygen molecules diffuse from the surrounding tissue into this micronucleus, following the concentration gradient. They effectively replace some of the nitrogen that was inside.
Okay, so swapping nitrogen for oxygen.
Exactly. But here's the key difference. oxygen is metabolically active. Unlike nitrogen, which is inert, the body actually uses oxygen. So the oxygen that enters the micronucleus is then consumed by the surrounding tissues.
Ah, so it gets used up.
Yes. And this metabolic consumption progressively reduces the overall gas volume inside the micronucleus, causing it to shrink. And if enough oxygen is delivered and consumed, it can lead to its complete removal from the tissue. It's kind of like filling a balloon with a gas that slowly gets absorbed away, making the balloon shrink.
That's a great analogy. And alongside this effect on the micronuclei themselves, exposure to hyperoxia, breathing high levels of oxygen, also causes a more general tissue denitrogenation. This is the well-known process where the inert nitrogen ordinarily dissolved in body tissues, according to Henry's law, based on the partial pressure of nitrogen in the breathing gas, and the ambient pressure diffuses back into the bloodstream.
And then out through the lungs.
Exactly. It's transported to the lungs, crosses the alveolar membrane, and is exhaled. By breathing pure oxygen, you eliminate nitrogen from the breathing gas, creating a really steep gradient that favors the movement of nitrogen out of the tissues into the blood and out via the lungs. This reduces the overall nitrogen load available to form bubbles when the pressure drops.
So you're doing two things: shrinking the bubble seeds, the micronuclei, and reducing the total amount of nitrogen gas dissolved in the tissues that could form bubbles in the first place.
Precisely. The source also mentions an intriguing, though currently poorly understood, mechanism potentially involving the lymphatic system.
Oh.
Yeah, it's proposed that oxygen exposure might somehow enhance the metabolism of lymphatic vessels. This could, in turn, promote the removal of proteins that are thought to coat or stabilize these micronuclei. If you remove the protein coat, perhaps the micronuclei become less stable or easier to eliminate. It suggests a more complex biological effect beyond just simple gas diffusion.
Interesting. It definitely highlights that we still have a lot to learn about the full picture here.
Absolutely. The authors also discuss the proposal that incorporating exercise might increase the preventative effects of oxygen pretreatment.
How would that work?
Well, the rationale is fairly straightforward. Exercise increases ventilation, meaning more nitrogen gets offloaded via the lungs. It also increases tissue perfusion and gas diffusion, which helps move nitrogen from deeper tissues into the blood where it can be transported away.
Okay. And the implication there could be quite significant for practical diving operations, right? If exercise really enhances denitrogenation, it could potentially allow for a shorter duration of oxygen pretreatment to achieve the same level of protection.
Exactly. That would be really valuable in time-constrained operational scenarios.
It's also important to note, though, that the protective effect isn't permanent. The observation is that the delay for the regeneration of this micronuclei population after such pretreatments can vary, but it ranges from just a few hours up to maybe 100 hours.
So the clearance offers protection for a significant window, but eventually they will reform.
Okay. A key study highlighted in the chapter is by Castagna and colleagues. They conducted a study using just 30 minutes of normobaric oxygen pretreatment administered before repetitive open water air dives. What did they find?
They found that this relatively short pretreatment significantly reduced decompression-induced bubble production. They assessed this non-invasively using Doppler ultrasound and a standardized bubble formation score.
And what was particularly surprising and clinically relevant about this study was that this protective effect, measured by those reduced bubble scores, actually extended to a subsequent dive.
Right, which is kind of counterintuitive because repetitive diving normally increases the overall nitrogen load and is associated with an increased risk of bubble production and DCS. The fact that a single 30-minute pretreatment offered this carryover protection suggests it triggers a pretty robust physiological response.
Okay. Now, more recently, researchers have directly compared normobaric oxygen pretreatment with hyperbaric oxygen pretreatment. What are the findings there?
Well, findings from recent studies cited suggest that compared to just normobaric oxygen, hyperbaric oxygen pretreatment may have an enhanced protective effect against DCS development in humans.
Could you give an example?
Sure. They detail a study showing that pretreatment with oxygen at 1.6 atmospheres absolute, that's 162.12 kilopascals, a relatively mild hyperbaric exposure for just 25 minutes, significantly reduced the bubble score detected with Doppler ultrasound when compared directly to normobaric oxygen pretreatment.
Suggesting more efficient nitrogen removal.
Exactly. It suggests a more efficient denitrogenation and perhaps denucleation processes occurring at that slightly elevated pressure. The higher partial pressure of oxygen just creates a steeper gradient for nitrogen washout.
Okay. Taking this concept even further, subsequent studies in open-water divers investigated breathing oxygen underwater during the dive itself, but at shallow depths, like 6 or maybe 12 meters of seawater. What did they show?
These studies demonstrated that this underwater oxygen breathing led to lower bubble scores than oxygen pretreatment performed at the surface before the dive.
That's intriguing. Why might that be?
Well, it suggests that maybe combining the hydrostatic pressure with the oxygen exposure during the initial phase of the dive might be even more effective than just surface pre-breathing alone. Perhaps the pressure itself enhances gas exchange or micronuclei dissolution in some way.
Okay. Finally, the source addresses a concern that's been raised in the field about the possible contribution of activated platelets to the pathology of decompression sickness.
Yes, and this is important. Recent work cited has actually demonstrated reduced platelet activation after hyperbaric oxygen, normobaric oxygen, and even that underwater hyperbaric oxygen pre-treatment.
And why is that significant?
Well, platelet activation is part of a pro-inflammatory and pro-thrombotic cascade that can really contribute to the severity of DCS symptoms. So, demonstrating reduced platelet activation suggests that oxygen pretreatment might not only reduce the sheer number of bubbles, but could also mitigate some of the downstream physiological damage they cause.
So it's not just physics, it's biology too.
Precisely. It opens up a new avenue for research into the mechanisms by which oxygen pretreatment protects against DCS, moving beyond just the physical aspect of bubble mechanics.
Okay, great. So to quickly summarize our dive into diving medicine, oxygen pretreatment is clearly a cornerstone of preventing decompression sickness. It leverages these principles of denitrogenation, washing out nitrogen, and micronuclei reduction, shrinking those bubble seeds.
Right. And studies confirm its effectiveness, with evidence suggesting hyperbaric oxygen and maybe even underwater oxygen breathing might offer enhanced benefits compared to just surface normobaric oxygen.
Importantly, the protection seems to extend even to repetitive dives, which is clinically relevant. And this new research indicating it can also mitigate downstream inflammatory consequences by reducing platelet activation is really quite exciting.
Absolutely. This area provides robust, real-world evidence for the power of oxygen preconditioning.
Okay, let's transition now from preventing these environmental insults to potentially mitigating the damage from necessary medical interventions. We're moving into Section 3, Hyperbaric Medicine Applications, bringing preconditioning to the clinic.
Right. And the chapter states that hyperbaric oxygen preconditioning has been increasingly used in patients before they are exposed to potentially dangerous clinical situations, and importantly, often with observed beneficial effects.
However, it's crucial to state up front, as the authors do, that the precise mechanisms of action for these beneficial effects in complex human clinical scenarios, well, they have not yet been fully ascertained or wholly translated into routine, widespread clinical practice.
That's a really key caveat. While we might see positive outcomes, the complete picture of how it's working in the human body in these specific disease states or surgical contexts is definitely still being pieced together. There's a gap between observing the effect and fully understanding the underlying biology to really optimize its use.
So one of the primary targets for oxygen preconditioning in the clinical realm is something called ischemia reperfusion injury, often abbreviated as IR injury.
Yes, this is a ubiquitous pathologic phenomenon in medicine. It occurs when tissue has been deprived of oxygenated blood flow for a period that's the ischemia phase. But then, paradoxically, when blood flow is restored, the reperfusion phase, the sudden reintroduction of oxygenated blood doesn't immediately heal the tissue. Instead, the reperfusion itself can actually increase the numbers and activities of damaging oxidants, leading to further injury.
It's a complex and frankly frustrating paradox, isn't it? The very act of restoring the life-giving oxygen delivery actually enhances the hazardous effects of the initial oxygen deprivation,
Right.
primarily by amplifying inflammation.
Exactly. You described it well earlier, like extinguishing a fire, the ischemia, and then throwing gasoline back on the smoldering embers, the reperfusion. That sudden rush of oxygenated blood and metabolic substrates, it fuels this cascade of damaging biochemical reactions.
And the source details two main pathways through which inflammation gets significantly enhanced during reperfusion. First, there's this massive release of pro-inflammatory cytokines and highly destructive reactive oxygen species.
The authors specifically name some of these reactive molecules. The hydroxyl radical, OH, which is extremely reactive, damages pretty much all biological molecules. The superoxide radical, OERO, an initial oxidant that can be converted to other damaging species. And hydrogen peroxide, AgERO, which also contributes to oxidative stress and inflammation.
These molecules, often called free radicals, are like tiny bombs going off at the cellular level, causing widespread damage to cell membranes, proteins, DNA.
Yeah, exactly. And the second pathway mentioned is the activation of the complement system. This is part of the innate immune system that, when it gets activated inappropriately during reperfusion, can recruit inflammatory cells and directly damage tissue cells.
And unfortunately, virtually all tissues in the body are susceptible to some degree of ischemia-reperfusion injury. It's a major factor in the damage caused by things like heart attacks, strokes, organ transplantation, and many surgical procedures.
Basic science research, particularly using animal models, has been absolutely fundamental in understanding IR injury and how preconditioning might work. These studies have helped demonstrate the varying tolerance and vulnerability of different tissues and organs to this type of insult.
The source lists examples like the kidney, liver, lungs, testes, brain, heart muscle, skeletal muscle, and the intestine.
Right. Each has unique metabolic needs and cellular structures that influence how well it withstands and recovers from IR.
The authors also note that some critical enzymatic pathways involved in the cellular response to ischemia and reperfusion are influenced by hyperbaric oxygen therapy. They give the specific example of the increased expression of HIF-1 alpha, that's hypoxia-inducible factor 1 alpha.
Which is interesting because HIF-1 alpha is a transcription factor that plays a central role in the cellular response to low oxygen conditions, hypoxia. The fact that hyperbaric oxygen, a state of high oxygen, can increase its expression suggests a complex signaling pathway is being activated. Maybe it's a form of hormesis, where a controlled stresses signal triggers protective adaptations.
Could be. And while animal models provided those initial insights, there has been a growing amount of clinical research in this area in recent years. This has been fueled by an increased understanding of the mechanisms and, importantly, the clinical causes of IR injury.
These causes can be natural, like blockages in blood vessels from atherosclerotic disease, arterial thrombosis or embolism, or maybe damage from vascular trauma.
And highly relevant for us as clinicians, the causes are frequently iatrogenic, meaning they are a necessary consequence of medical interventions. Prime examples include organ transplantation, where the donor organ inevitably experiences ischemia during removal, preservation, and transport, or procedures requiring a prolonged bloodless surgical field. Think tourniquets in orthopedic surgery, or clamping major vessels during complex vascular or cardiac procedures.
So, in this clinical context, where ischemia is anticipated or just unavoidable, the goal of oxygen pretreatment is precisely what we defined earlier: to activate those endogenous protective mechanisms before the insult occurs. The hope is that by priming the tissue, it'll be better prepared to withstand the period of ischemia and, crucially, to minimize the morphologic and functional damage, the structural changes and loss of function that result from the prolonged ischemic insult and that subsequent damaging reperfusion phase.
Okay, so that's the overarching goal. Let's now drill down into specific clinical areas where hyperbaric oxygen preconditioning is being explored or applied, starting with the major one, cardiac surgery.
All right. Subsection 3.1, cardiac surgery. The source states quite clearly that despite constant improvements in surgical techniques, anesthesia, myocardial protection strategies, ischemia reperfusion injury is considered practically inevitable during many cardiac surgical procedures.
And the primary cause identified here is IR injury resulting specifically from aortic clamping during cardiopulmonary bypass, or CPB.
Right. During procedures like coronary artery bypass grafting, CABG, the aorta is clamped to stop the heart, allowing surgeons to operate on a still, bloodless field while the heart-lung machine takes over circulation. That period the aorta is clamped is the ischemic time for the heart muscle, and injury occurs upon reperfusion when the clamp comes off and blood flow is restored. This IR is a really significant cause of perioperative complications and can contribute to mortality in procedures like CABG.
And the source details the most frequent IR complications seen in this setting. Things like reperfusion-induced arrhythmias, which can be life-threatening. Myocardial stunning, which is a temporary but often prolonged loss of the heart muscle's ability to contract effectively. Microvascular obstruction, where the tiny capillaries in the heart muscle get blocked, further impeding recovery. And direct reperfusion injury due to apoptosis or programmed cell death, and other structural and functional changes happening right inside the myocardiocytes, the heart muscle cells.
And clinically, how do these complications manifest?
Well, in significant ways. In the acute setting, they can lead to low cardiac output syndrome, where the heart just can't pump enough blood to meet the body's demands, often needing drugs or even mechanical support. And in the chronic setting, repetitive or severe IR injury can contribute to the development or worsening of heart failure down the line.
Okay. Now, the concept of heart oxygen preconditioning, specifically preparing the heart muscle with oxygen before an ischemic insult, that was first described decades ago in a canine myocardium IR injury model. So animal research provided that initial proof of concept that such pretreatment could actually confer protection.
And since that early animal work, there's been intense research into possible applications of preconditioning before human cardiac surgery. This includes exploring various stimuli, not just oxygen, but things like using volatile anesthetic gases during anesthesia induction, or, interestingly, using artificially induced peripheral limb ischemia.
Ah, yes, the remote ischemic preconditioning idea. Inducing brief ischemia in a limb, usually with a blood pressure cuff, has shown some promising results in triggering protective pathways that seem to benefit distant organs, like the heart.
And this peripheral limb ischemia model has revealed what the source calls an interesting twofold timing of increased protection. What does that mean?
It refers to two distinct periods when protection is observed after that brief ischemic stimulus in the limb. There's an early first window, which develops within minutes of the limb ischemia and lasts for just a few hours. You can think of it as a rapid, short-acting protective response.
Okay, quick onset, short duration.
Exactly. And then there's a later second window of protection. This occurs from about 12 to 24 hours after delivering the initial ischemic stimulus and can last for a more prolonged period, maybe up to 3 to 4 days.
So a delayed but longer lasting effect.
Right. It's almost like a delayed adaptive response, maybe like the spaced repetition we use for learning, but for cellular defense mechanisms. The source notes, interestingly, that this observation of timed protective windows has also been applied to the prevention of high-altitude illness.
Fascinating. Okay, now let's look specifically at the evidence for hyperbaric oxygen preconditioning before cardiac surgery. The chapter summarizes findings, notably in Table 1, linking HBO preconditioning with better outcomes after CABG surgery.
Yes, and the overall picture emerging from these studies indicates some prominent positive effects of hyperbaric oxygen preconditioning on the cardiovascular system and patient recovery. These include things like better cardiovascular hemodynamic parameters, improved measures of heart function, maybe stroke volume or cardiac output, reduced length of stay in the intensive care unit and the hospital overall, fewer perioperative complications, and reduced indicators of cardiac injury, like enzyme release.
Now, a key insight from these trials, highlighted by the authors, is that hyperbaric oxygen pretreatment appears most useful for patients undergoing on-pump CABG surgery, those procedures done with cardiopulmonary bypass.
Right. It did not seem to show significant benefit in off-pump or beating heart CABG cases, where the aorta isn't clamped and CPB isn't used.
Which strongly supports the hypothesis that the primary target of the HBO preconditioning here is specifically the ischemia-reperfusion injury associated with that period of aortic clamping and CPB.
Makes sense. And beyond the direct benefits to the heart, trials in this field have also documented some additional positive findings in hyperbaric oxygen pretreated patients. These include a reduced systemic inflammatory response, which is a common and detrimental consequence of CPB.
Right.
Reduced neuropsychometric dysfunction, meaning better cognitive outcomes post-operatively, less cerebral inflammation, which likely contributes to that better brain function, and overall increased cerebral protection. So the benefits potentially extend beyond just the heart muscle itself.
Okay, let's take a closer look now at the studies summarized in that Table 1, as they provide the concrete evidence base we're discussing. There are 4 distinct studies presented there.
All right, first up, Study 1 by Ness and colleagues. This was a randomized controlled trial. The hyperbaric oxygen protocol involved 3 sessions administered at 2.4 atmospheres absolute, that's 243.18 kilopascals.
Okay, what do they measure?
The outcomes they measured included inflammatory response markers, neuropsychometric dysfunction scores, and the incidence of perioperative complications, and the main results. They indicated that hyperbaric oxygen pretreatment resulted in a reduced inflammatory response, reduced neuropsychometric dysfunction, and a reduction in perioperative complications compared to the control group that didn't get the HBO.
So pretty significant findings suggesting a broad protective effect, impacting both organ systems and overall recovery.
Yes. Then, Study 2 by Ogura et al., also a randomized controlled clinical trial. Their HBO protocol involved just a single session, but at 2.5 atmospheres absolute, 253.32 kilopascals, for a duration of 90 minutes.
And their outcomes?
They measured cardiovascular hemodynamic parameters, things like stroke volume, SV, and left ventricle stroke work, LVSW. They also looked at length of stay in the ICU, perioperative complications, and blood loss.
And the results?
The main results showed tangible improvements in heart function. HBO resulted in increased stroke volume and left ventricle stroke work, suggesting the heart was pumping more effectively. It also led to a decreased pulmonary vascular resistance, PVR, reducing the workload on the right side of the heart. Clinically, they observed a reduced length of stay in the ICU and a reduction in perioperative complications compared to the control group.
Okay, 2 positive studies so far. What about study 3?
Study 3, conducted by Lee and colleagues, was another randomized controlled clinical trial. Their HBO protocol was a bit different. 1 session per day for 5 consecutive days, administered at 2.0 atmospheres absolute, 202.65 kilopascals, for 60 minutes per session.
And they measured quite a range of outcomes, right?
No, they did. Very relevant ones for cardiac injury and recovery. Cardiac injury markers like troponin I, a sensitive marker of heart muscle damage, the need for inotropic support, drugs to improve heart contractility, duration of mechanical ventilation, length of stay in both the ICU and the hospital overall, hemodynamic parameters, and serum catalase activity. That's an important antioxidant enzyme we mentioned earlier.
And the results were pretty comprehensive.
Yes, quite striking. Hyperbaric oxygen led to decreased levels of troponin I, indicating less myocardial damage. Patients required decreased inotrope use and fewer ventilator hours, suggesting better acute cardiac and respiratory function. They also had decreased length of stay in both the ICU and the hospital. Hemodynamic parameters were improved, and interestingly, serum catalase activity was increased in the treated group, pointing towards an activation of the body's own antioxidant defenses. They also noted decreased levels of S100B and neuron-specific analase, which are markers suggesting cerebral protection, specifically in the on-pump patients who received the HBO pretreatment.
Okay, that sounds very promising. What about the last one, study 4?
Finally, Study 4 by Jason et al., another randomized controlled clinical trial. Their HBO protocol was at 2.4 atmospheres absolute, 243.18 kilopascals, delivered in 2 separate 30-minute sessions. But instead of broad clinical outcomes, they focus on specific molecular markers within the heart muscle itself. They measured the expression of endothelial nitric oxide synthase, ENOS, and heat shock protein 72, HSP72, on right atrium biopsies taken during the surgery.
What did they find at that molecular level?
Well, the main results of this particular study showed no significant changes in the levels of these specific proteins, ENOS and HSP72.
So clinical benefit seen in other studies, but not necessarily reflected in these specific molecular markers in this one.
Exactly. And this finding is important because it highlights the complexity of the mechanisms involved. Even when clinical benefits are observed, the exact molecular pathways being activated might be elusive, or they might involve different targets than the ones hypothesized. It suggests the protective effect might not universally manifest as increased expression of these specific proteins in all areas of the heart or under all protocols used.
Right. Okay, so to consolidate the findings specifically on cardiac surgery, ischemia reperfusion injury from cardiopulmonary bypass is a major issue, particularly in on-pump CAG, causing significant complications.
Preconditioning strategies, including novel methods like peripheral limb ischemia with its interesting first and second windows of protection, are being studied to mitigate this.
And evidence from several randomized controlled trials, like those in Table 1, suggests that hyperbaric oxygen preconditioning, particularly in those on-pump cases, can lead to concrete clinical benefits. Things like better heart function, reduced complications, shorter ICU and hospital stays, less inflammation, and potentially even some cerebral protection.
But, as highlighted by studies like Jason's, while the clinical outcomes look promising in specific contexts, the exact molecular mechanisms involved are still areas of active investigation.
Okay, moving from the heart now to another vital and highly sensitive organ system, the central nervous system.
All right. Subsection 3.2, central nervous system. The brain and spinal cord, they have a unique and unfortunately very high sensitivity to ischemia, that interruption of blood flow. This makes neurological tissues particularly vulnerable to IR injury.
Why are they so vulnerable?
Well, it stems from several factors. They have an exceptionally high metabolic rate. They have an almost absolute dependence on continuous glucose delivery for energy neurons, store very little glycogen themselves. And then there are the peculiar features of neurons themselves. They're highly specialized, terminally differentiated cells that are relatively poor at withstanding and recovering from periods of metabolic deprivation compared to many other cell types in the body.
Okay. Now, the source notes that despite reportedly excellent results for treating several acute and chronic affections of the central nervous system with hyperbaric oxygen, presumably referring to conditions like carbon monoxide poisoning, air embolism, maybe post-stroke recovery where HBO is used therapeutically after the injury.
Right.
And despite a general increase in interest, most existing literature specifically on preconditioning the central nervous system with HBO is currently restricted mostly to animal models.
Yes, the preclinical evidence is quite compelling, actually. Reports from animal models indicate that hyperbaric oxygen preconditioning, when applied before an anticipated brain or spinal cord ischemic insult, seems to cause a kind of controlled oxidative stress.
Controlled oxidative stress,
A
like a
primer.
small dose of stress to trigger defenses?
Exactly. It's not enough stress to cause damage, but it's perceived by the cells as a signal, triggering a protective response. This controlled stress then leads to the subsequent transcription, the copying of genetic information from DNA into RNA of various antioxidative enzymes within the central nervous system.
Which enzymes are we talking about?
The source lists specific examples whose expression is increased in these animal models. Catalase, C8T, superoxide dismutase, SOD, peroxidases, and heme oxygenase 1, HO1. These are all key players in the body's defense against those damaging reactive oxygen species.
Okay.
The studies also show induction of heat shock proteins, HSPs, which help protect cellular components from damage, and enzymes like NRF2, nuclear factor erythroid 2 related factor 2, and enos-NOS, endothelial and neuronal nitric oxide syntheses, which are involved in regulating oxidative stress responses and producing signaling molecules like nitric oxide. Essentially, the brain is being primed, told to ramp up its internal antioxidant and cellular protection systems before the hit comes.
So in the lab, the mechanism looks really promising, triggering the brain's own defenses before potential stroke or surgical ischemia. However, and this is a significant caveat, clinical trials designed specifically to assess the utility of hyperbaric oxygen pretreatment on overall neurological outcomes in humans. Well, they have failed thus far to show a consistent broad benefit.
That's a really crucial disconnect, isn't it, between those strong preclinical findings and the human clinical trial results. The source does suggest potential reasons why these clinical trials might have been biased or failed to detect a benefit.
Such as?
Well, the population studied often consisted mainly of older adults who typically have multiple comorbidities and are often on polytherapy, taking several medications. These factors introduce significant variability and complexity, making it really challenging to isolate the specific effect of the hyperbaric oxygen pretreatment against the backdrop of multiple other health issues and drug interactions.
Yeah, it's hard to design a study powerful enough to detect maybe a subtle preconditioning effect in such a complex patient group. However, the source then brings up a specific, very relevant context. Neurological impairment is frequently reported after cardiac surgery, as we just touched upon in the previous subsection.
Yes, this is a significant concern for patients undergoing procedures like CABG.
Oh.
The sequelae, the resulting neurological problems, can range quite a bit in severity. They can be relatively mild, like postoperative cognitive dysfunction, sometimes called post-op cognitive decline or post-op fog and postoperative delirium, that acute state of confusion. Or they can be as severe as an overt stroke.
And the cause isn't simple, right?
No, the etiology of these cardiac surgery-related cerebral injuries is likely multifactorial, not due to a single cause. It probably arises from a complex interaction among various factors. Things like cerebral microemboli, tiny clots or particles traveling to the brain, global cerebral hypoperfusion, periods of reduced overall blood flow during or after surgery, inflammation, both systemic and within the brain itself, cerebral temperature modulation during the cooling and rewarming phases of CPB, and also individual genetic susceptibility to injury.
Okay. And interestingly, in this specific clinical field addressing neurological issues, specifically in the context of post-cardiac surgery, the source states that trials of hyperbaric oxygen therapy preconditioning have actually shown reduced post-operative cognitive dysfunction.
Ah, so that seems to contradict the broader negative findings.
It does, or at least adds nuance. This appears to be a specific area where a benefit has been detected in human trials. It suggests that while hyperbaric oxygen preconditioning might not offer universal neurological protection across all types of insults in all patient groups, it might be effective in mitigating the specific constellation of factors leading to cognitive dysfunction, particularly after cardiac surgery.
Okay, that makes sense. Targeted benefit, perhaps.
Exactly. So, to summarize our look at the central nervous system applications, we have this robust preclinical evidence from animal models showing HBO preconditioning can trigger powerful endogenous antioxidant and cellular defense mechanisms, essentially priming the brain against ischemia via controlled oxidative stress.
Right. but broad clinical trials assessing general neurological outcomes have largely been disappointing, possibly confounded by the complexity of older patients with comorbidities.
The notable exception seems to be the specific context of post-cardiac surgery, where some trials suggest HBO preconditioning can reduce postoperative cognitive dysfunction, highlighting the potential for targeted benefit in specific high-risk scenarios.
Okay, let's expand our scope now to another major surgical area where oxygen preconditioning is being investigated: major abdominal surgery.
Right, subsection 3.3, major abdominal surgery. The source indicates that studies have demonstrated that both normobaric and hyperbaric oxygen preconditioning can confer benefits to other organ systems beyond just the heart and brain, suggesting maybe a more generalized protective principle is at play.
They provide the example of the liver, where studies have shown that oxygen preconditioning can induce heme oxygenase 1, HO1. We mentioned this enzyme before. It's known to play a significant protective role in liver ischemia reperfusion injury. So again, it points towards the activation of endogenous antioxidant and cytoprotective pathways as a key mechanism.
And there's a specific clinical finding mentioned too.
Yes, that hyperbaric oxygen preconditioning has been shown to reduce the incidence of pulmonary infections in a specific patient population: oncologic patients undergoing a pancreaticoduodenectomy, the Whipple procedure, when this complex surgery was performed with open abdominal access.
Okay, the Whipple is a major operation with a significant risk of postoperative complications, including infections, so a reduction in pulmonary infections would definitely be a meaningful clinical benefit.
Absolutely. The source then dedicates significant attention to a larger, more detailed study completed by Bosco and Caporesi themselves. This study investigated preoperative hyperbaric oxygenation, specifically in patients scheduled to receive pancreaticoduodenectomy for premalignant or malignant periampullary tumors.
And this was done in collaboration with surgeons using robotic techniques.
Yes, with support from a large group of pancreatic surgeons at Advent Health in Tampa, Florida, a center known for utilizing robot-assisted surgical techniques.
Okay. And it was a randomized study.
Yes, patient assignment was randomized. There were 17 patients in the treatment group. Their hyperbaric oxygen protocol involved 2 90-minute HBO therapy exposures at 2.4 atmospheres absolute. Each session included a single air break, which is standard practice.
And the timing?
Specific timing.
Yeah.
One session was administered on the evening before surgery, and the second session was administered again on the morning of surgery.
Okay. And the control group?
The control group consisted of 16 patients who didn't receive any specific pretreatment before their intervention. The researchers measured a panel of inflammatory mediators, those markers in the blood indicating systemic inflammation. They looked at TNF-alpha, IL-6, IL-10, VEGF, and ESR.
And they also tracked patient symptoms.
Yes, they tracked parent-reported outcomes using a self-assessed pain scale, and they took these measurements at multiple time points, preoperatively, and then on postoperative days 1, 3, 5, and also day 30, allowing them to track the trajectory of inflammation and pain over time.
Okay, so what were the results when looking at standard clinical metrics?
Well, this is where it gets interesting. The results presented a picture of no significant differences between the group that received the HBO therapy and the control group for several standard metrics. These included patient characteristics like age, sex, BMI, tumor size, and surgical factors like operative duration and estimated blood loss.
What about length of stay?
Crucially, also no significant difference in the length of hospital stay. The specific values cited were 5 plus or minus 1.18 days for the treated group versus 5 plus or minus 0.7 days for the controls, essentially identical averages. And also no significant difference in the 30-day readmission rate, 1 readmission in the HBO group versus 2 in the control group.
Okay. What about those inflammatory mediators they tracked?
Looking specifically at those, they observed the expected pattern following major surgery. ESR, IL-6, and IL-10 all increased temporarily in the postoperative period before returning towards normal levels. TGF-beta initially fell before rising. However, the critical finding reported by the authors was that there were no sustained differences in the levels of these measured inflammatory mediators between the two groups, with or without HBO therapy, across the measured time points.
So, based on those specific inflammatory markers, the HBO preconditioning didn't seem to significantly blunt the overall inflammatory response to the surgery in this study. Were there any positive signals in other outcomes?
Yes, there were a couple. Regarding pain, the authors reported that at postoperative day 30, pain levels, as assessed by that self-report scale, were significantly lower, and importantly, had returned to baseline levels in the group that received HBO therapy compared to the control group. This suggests a potential benefit in longer-term recovery and patient comfort.
Okay, reduce pain at 30 days. What about complications?
There was also a finding related to complications. Specifically, they noted 0 complications of Klebsiella grade class 2 or higher in the HBO group versus 1 such complication in the control group. Now, this difference, while based on a very small number of events, 0 versus 1, was assessed after a long follow-up period of 50 months and did reach statistical significance with a p-value of 0.03.
So statistically significant, but maybe questionable clinical significance given the numbers?
It hints at a potential long-term reduction in certain types of complications. But yes, the clinical meaningfulness of preventing a single class 2 complication over such a small sample size needs careful consideration.
So given the overall lack of significant differences in those inflammatory markers and major clinical outcomes like length of stay and readmission, what was the study's overall conclusion?
Well, the conclusion presented by the authors is that this extensive study is not supporting postoperative improvements after their specific pre-oxygenation protocol for this type of surgery.
But they added an important caveat, right? Especially regarding the inflammatory mediators.
Yes, a very important caveat. They suggest that a notable difference might have been observed in the minor changes in inflammatory mediators during those first few postoperative days, changes which weren't sustained over the full measurement period. And they propose that this subtle effect, or perhaps the lack of a larger sustained effect on inflammatory markers, might actually be due to the surgical approach used in this study.
Because it was robot-assisted.
Exactly. The fact that the surgery involved robotic assist, which is typically associated with less tissue trauma and thus a potentially minimized innate inflammatory response compared to a traditional open abdominal surgery, might have overridden or masked any subtle anti-inflammatory effects that the HBO preconditioning protocol might have otherwise had. The baseline surgical insult was potentially just less pro-inflammatory to begin with.
That's a really crucial point about context. Okay, so to briefly summarize the findings regarding major abdominal surgery, oxygen preconditioning shows promise in other areas, like enhancing liver protection via HO1 induction, and was associated with reduced pulmonary infections after open Whipple procedures in one study.
Right. However, this detailed study by Bosco and Camporese looking at HBO preconditioning before robot-assisted pancreatic duodenectomy found no significant differences in inflammatory markers or most key clinical outcomes like length of stay.
But, importantly, it did show significantly lower patient-reported pain at 30 days, and that statistically significant, though numerically small, reduction in one complication category over a long follow-up. And the authors themselves suggest the minimally invasive nature of the robotic surgery might have significantly influenced the lack of impact on those early inflammatory markers.
Okay. Let's step back now and try to consolidate our understanding of the hyperbaric medicine applications we've explored across these areas. We've covered the investigation of HBO preconditioning in 3 major clinical areas: cardiac surgery, focusing on CAB, protection of the central nervous system, and major abdominal surgery, specifically pancreatic duodenectomy.
Right. In cardiac surgery, especially on-pump procedures, evidence from randomized trials seems to provide support for HBO preconditioning, leading to tangible clinical benefits: better heart function, fewer complications, shorter ICU and hospital stays, maybe even some benefits for cerebral protection and reduced inflammation.
For the central nervous system, we saw that picture of strong preclinical evidence from animal models showing activation of protective antioxidant enzymes and heat shock proteins via controlled oxidative stress. But translating this to consistent, broad neurological benefits in human clinical trials has proven challenging, possibly due to patient complexity and confounders, although there is that signal of potential benefit in reducing postoperative cognitive dysfunction, specifically after cardiac surgery.
And in major abdominal surgery, the findings are perhaps the most mixed. While there are hints of benefit, like reduced pulmonary infections in one study and reduced long-term pain and potentially fewer complications in another, the larger trial by Bosco and Camporese didn't show overall improvements in inflammatory markers or length of stay. This raises questions about maybe the optimal protocol, patient selection, or, as they suggested, the significant influence of modern surgical techniques like robotic assist.
Yeah, and across all these clinical areas, a major recurring theme is the ongoing challenge of fully understanding the precise mechanisms activated by oxygen preconditioning in humans in the context of specific diseases and surgical insults. Translating the promising findings from basic science and these initial clinical trials into widespread, evidence-based, guideline-supported clinical practice, well, it requires overcoming significant hurdles in study design, patient selection, and protocol optimization.
Definitely. Which brings us very naturally to our final section, looking forward. Section 4. Perspectives of future research. Where do we go from here? The chapter points towards several quite exciting avenues ripe for further investigation.
One particularly interesting finding highlighted for future research is the effect of underwater hyperbaric oxygen treatment, specifically looking at peripheral blood lymphocytes. They found that compared to HBO exposures administered in a dry hyperbaric chamber, exposures underwater had distinct effects.
Oh, what kind of distinct effect?
Specifically, the activity of the catalase enzyme, that key antioxidant in circulating lymphocytes, was higher when the HBO was administered underwater. Additionally, the messenger RNA gene expression patterns for other antioxidant enzymes like superoxide dismutase and glutathione peroxidase were also higher underwater.
So the lymphocytes seem to be ramping up their production of these protective enzymes more significantly in the underwater environment.
That's what it suggests. And crucially, alongside these signs of enhanced antioxidant defense, they found no increase in intracellular calcium levels in lymphocytes exposed to HBO underwater. Elevated intracellular calcium is often a marker of cellular stress, injury, or even impending cell death.
So its absence suggests less cellular stress.
Potentially, yes. The absence of this increase suggests that calcium homeostasis was preserved, possibly indicating less cellular stress or damage despite that enhanced enzymatic activity.
Okay. And how are these results interpreted?
Both results, the enhanced antioxidant defense activity and the preserved calcium homeostasis, were interpreted as suggesting an enhanced antioxidant defense in lymphocytes during underwater HBO exposure compared to exposures in a chamber. However, the authors are very clear that these mechanisms need further assessment to fully understand why the underwater environment makes a difference. Is it the hydrostatic pressure? Temperature? Some other environmental factor? It's a really novel area.
Very intriguing. What other areas need more research?
Another area requiring more rigorous investigation is the potential usefulness of HBO preconditioning in patients admitted for unstable angina or acute myocardial infarction who are undergoing percutaneous transluminal coronary intervention (PCI) or coronary stenting.
Okay. What's the current evidence there?
Well, the source states that only one study has specifically addressed this question of using HBO before PCI in acute coronary syndromes. And importantly, they classify the results of the single study as questionable.
Questionable why?
Because of a restricted sample size, it was just too small to draw definitive conclusions and, critically, a non-rigorous methodology. The methodological issue was that among the patients allocated to the HBO arm of the study, some received the HBO as pre-treatment before the PCI, while others received the HBO after the procedure as post-treatment.
Ah, so they mixed pre- and post-treatment in the same group.
Exactly, which makes it impossible to isolate and evaluate a true preconditioning effect. So, despite the theoretical rationale for protecting the heart muscle during the IR insult associated with reopening a blocked coronary artery, the question of whether HBO preconditioning before PCI is beneficial in patients with acute coronary syndromes remains largely unanswered by robust clinical evidence.
Got it. These better studies. What else?
Skin flap grafting is another area. This is a widely used technique in plastic and reconstructive surgery, and it's highly relevant because the survival of these grafted skin flaps is often significantly impacted by ischemia-reperfusion injury, which can occur during the transfer and revascularization of the flap.
And the basic science looks promising here.
Yes, studies in animal models, typically rats, have shown promising findings. HBO pretreatment has been associated with multiple potential benefits for flap survival. Things like antioxidant effects, combating damaging reactive oxygen species, better flap vascularization, improved blood vessel formation and function, decreased expression of adhesive molecules on T cells, which might help reduce inflammatory responses or immune rejection of the flap, and overall increased resistance to IR injury in these animal models.
So very encouraging results in the lab demonstrating plausible biological mechanisms for benefit.
Absolutely. However, as the source appropriately emphasizes, the clinical usefulness of these observations will absolutely need confirmation in human studies. What works in a tightly controlled rat model doesn't always translate directly to complex human patients with different comorbidities and surgical variables. Common theme there.
Indeed. Any other exciting future fields mentioned?
Yes, the interaction of hyperbaric oxygen therapy with various drugs is highlighted as an exciting future research field. This is because oxygen, particularly at high pressures, can influence numerous biochemical pathways in the body that are also affected by medications.
Can you give an example?
They provide a specific example from research by Yang and colleagues who suggested a protective effect of HBO treatment against indomethacin-induced enteropathy, that's damage to the small intestine caused by this particular NSAI. This hints at the potential for HBRs to maybe mitigate drug toxicity, which could be a vast area for future research.
Wow, yeah. Now, future investigations trying to translate these concepts into clinical practice, they must also carefully consider important confounding effects, right?
Definitely. Numerous existing diseases and medications that patients may have or be taking can significantly influence key cellular pathways that interact with or modify the effects of oxygen preconditioning. These include pathways involved in nitric oxide synthesis, apoptosis, programmed cell death, autophagy, that cellular self-cleaning process, and gene transcription. These factors can make it really challenging to study and predict the effects of oxygen preconditioning in real-world patient populations and absolutely need to be accounted for in study design and analysis.
So how did the authors suggest moving forward to tackle this complexity?
To successfully move these promising findings from basic science and preliminary clinical observations towards clinical translation, the authors strongly suggest a multidisciplinary approach. This would require close collaboration between hyperbaric medicine specialists, surgeons from the relevant disciplines, cardiac, neuro, abdominal, plastic, anesthesiologists, critical care physicians, and basic scientists. This collaborative effort is needed to design appropriate studies, really understand the underlying mechanisms, and determine the optimal patient populations and protocols.
And the ultimate goal isn't just research papers.
No. The ultimate goal, as they see it, is the integration of both normobaric and hyperbaric oxygen preconditioning into consensus-based international guidelines for specific clinical scenarios where the evidence eventually becomes sufficiently robust. That would signal that these techniques are recognized as safe, effective, and recommended practices.
Okay, so to bring together these perspectives on future research, we need investigations to understand those intriguing enhanced antioxidant effects seen with underwater HBO. The role of HBO preconditioning in acute coronary syndromes needing PCI requires robust clinical trials, as current evidence is weak due to methodological limitations.
Right. Promising animal data on improving skin flap survival needs confirmation in human studies. Exploring interactions with drugs, like potentially mitigating indomethacin damage, is an exciting new frontier.
And all future research must grapple with those confounding factors like underlying diseases and medications that influence cellular pathways. And the path towards clinical integration and inclusion in guidelines really requires that collaborative, multidisciplinary approach.
Well put.
Wow, what an extensive deep dive into Chapter 19. We've really journeyed from the fundamental concepts of pretreatment and preconditioning, this idea of preparing the body's biology before an anticipated insult occurs, through its established role in diving medicine, where it demonstrably helps prevent decompression sickness by clearing nitrogen and those bubble seeds, and maybe even mitigating inflammatory responses.
And we've explored the fascinating, though clearly still evolving, clinical applications in hyperbaric medicine. We saw promising, sometimes mixed evidence for HBO preconditioning in major surgical contexts like cardiac surgery, where trials suggest benefits for heart function, recovery time, and even neurocognitive outcomes in those on-pump cases.
We looked at the central nervous system, noting that strong preclinical rationale contrasting with the challenges in human trials, except perhaps for that signal of benefit in reducing post-cardiac surgery cognitive dysfunction.
Right. And we examined major abdominal surgery, where while broad inflammatory benefits weren't always seen, there were intriguing findings regarding reduced long-term pain and potentially fewer complications, alongside that important realization that surgical technique itself can significantly influence the observed outcomes.
It's definitely clear from this exploration that while basic science has made strides in identifying potential mechanisms, particularly around activating endogenous antioxidant and protective pathways, the precise ways these mechanisms translate into observable clinical benefits in complex human patients are still being fully elucidated.
Absolutely. And there's significant work ahead, requiring careful, multidisciplinary research to overcome confounding factors and translate promising findings into reliable, widespread clinical practice that could eventually shape those international guidelines we talked about.
So for you, our specialist clinician listener, the insights from this chapter offer more than just, interesting facts.
Yeah.
They provide a window into potential future strategies for patient care, for risk mitigation, and for optimizing outcomes in some of the most challenging medical and environmental scenarios you might encounter. It's worth considering how these principles of preparing the body might intersect with the specific risks and challenges inherent in your own area of practice. And that brings us to a thought-provoking question to leave you with, building directly on the patterns and challenges discussed in the source material. Given the varying success we've seen across different organ systems, heart, brain, liver, gut, and across different surgical approaches like on-pump versus off-pump cardiac surgery or open versus robotic abdominal surgery, what are the truly critical variables that determine the effectiveness of oxygen preconditioning?
That's the million-dollar question, isn't it?
It really is. Are they primarily related to the stimulus itself, the exact oxygen protocol used, the pressure, the duration, the timing relative to the insult? Are they related more to the target tissue, its inherent metabolic needs, its specific susceptibility to IR injury, its pre-existing health status, maybe even genetic factors? Or are they most dependent on the specific type and severity of the insult itself? The duration of ischemia, the characteristics of the reperfusion, the degree of associated inflammation or microembolism.
Which of these factors, or maybe what combination of factors, holds the key to predicting when oxygen preconditioning will work, how well it will work, and perhaps what mechanisms it will primarily activate in that specific scenario? And how can you, in your clinical observations, your critical appraisal of future literature and any potential research involvement, contribute to identifying these crucial determinants to help move this complex but really exciting field forward towards clearer guidelines and ultimately improved patient care?
Something substantial to think about until our next deep dive.